Thank you very much, Scott, for welcoming me to this audience. And it's a pleasure for me to be here to talk about the international perspective of cognitive impairment. I begin with this slide mainly to show you that it's 100 years since Makerere University started, and we are currently having celebrations to that effect. You're welcome to visit Makerere. So my focus of this discussion is to generally discuss on cognitive impairment on the international perspective. I guess what the people who are making the program were looking at was to look beyond the USA and what happens elsewhere. I'll try my level best to do that, but of course I'm aware that there are so many people in the room here who I know do a lot of international work in many different places. So if I do not cover what it is that you may be involved in, bear with me. And then we'll also talk about considerations for future research and implementation. Oops, I'm sorry. So I'll begin with a case study. So the case study is not actually about what you're seeing on the slide. The case study is a client I have been seeing for over possibly 10 years. This young lady, who was at the time about 33 years of age, was noted to be deteriorating in their cognitive functioning in the clinic, but also in the home. They noticed that she could not carry on activities within the home. She would get lost when she would go out into the garden to, look for food. She could not, do house chores and complete them. And what concerned me at that time when she came is that she was being escorted to the clinic by her 72-year-old mother as the only primary caretaker. So those are the challenges we face on the international scene when we get people who have cognitive impairment, that usually the caregiving person is going to have to be a family member, but most of the times it's going to be the mother or lady or someone. We have very limited human resource that can look after these individuals. So we made a documentary about her in the clinic, and to raise awareness about HIV in the community and the effects it has on the brain. And we were fortunate at that time that we did have some studies that were doing CSF viral loads. So we had a viral load done on her, because typically we do not, and found that she had a very, she was having viral escape, and that's why she had been failing on her HIV regimen. We did change the HIV regimen, and she started to improve. A few years down the road, the mother died, unfortunately, which was very sad, because now they kept on moving her about between, people who who could look after her, until the introduction of DTG in our setting, which is maybe about 5 years ago. And it was amazing to see her maybe about 3 weeks ago. And she could tell me who everyone is, who is around her, and they were telling me she's able to do chores in the house and, be able to carry on activities. So what's happening internationally, that if we do have antiretroviral therapy, it does change. But now we have a problem, because the availability of that antiretroviral therapy is becoming limited, for reasons I'm not going to go into in this conference, at least for Uganda. That it may not be enough to get to everyone that actually does need it, despite us having continued, prevalence of HIV in the community. So the reason I put up, just to highlight why I put up the slide on this, was to show that DTG does actually work, as has been proven by other researchers. So this slide too is also never changing with a high prevalence of HIV in low and middle-income countries will remain with the hugest burden. And of course, the literature also shows that people who have cognitive impairment are most likely going to be in these very places for various reasons, like late presentation for treatment, and hence which results into them having complications as a result of HIV disease that could also involve the brain. We are also not doing very well in terms of having everyone who needs treatment getting onto treatment and being virally suppressed, as you can see here. Earlier on in the morning, someone asked a question about late presentation, and the WHO puts that figure at about 22 to 25% of people who come really late for clinical care. We still, sometimes you think you've been in the field for a very long time and you would think everyone would know where to go if they got HIV, but we still have those challenges, and of course there's still a lot of stigma that impacts as to whether people do come for treatment or they do not. There was a question on clade subtypes and whether these affect cognitive functioning. The studies that have been conducted do show that people who have a clade subtype D may be having more expression of HIV dementia versus C versus B versus A. So when you look at the different geographic locations of where these clades may be, that gets into the picture for one to appreciate who may be more affected than the other, and therefore plan for them accordingly. The other question that I found in the literature as I was preparing for this is people having controversy as to whether HIV cognitive impairment remains as a subcortical problem or whether it is also a cortical disease, if I could put it that way. And from work that has been done by Heaton, Sisk, and others, they seem to confirm that it is, we should still look at it as a subcortical dementia and not a cortical dementia. Well, there are other people who may say, no, it isn't, but that's the argument that is on the floor. And when it gets to the different types of cognitive domains that are affected, and this is where, some of the questions that are being raised this morning, as there are so many other things that can still affect cognition. How do we delineate that which is coming out of HIV and that which is coming out of other things like comorbidities? So the RDoC framework, which is really being encouraged for much of the research we're doing in mental health now, encourages that we put these considerations as you plan, different studies, because there's certainly not the one thing that may be causing cognitive impairment. For example, as people grow older, is it also the fact that the increasing age itself is causing the cognitive impairment, and maybe not the ART toxicity that this person has been on for rather a long period of time. Someone already showed the slide on the different comorbidities that can happen as people age. We just have to be aware of all these things and the impact that they have on the individual. As regards the pathological mechanisms, these have always been what's been postulated: the immune activation, the blood-brain barrier dysfunction, and the virus-induced toxicities that come from the drugs that are used. In other settings other than the USA, sometimes we still have access to drugs that may be more neurotoxic than what would be prescribed here. But I guess there are more studies that need to be looked into in appreciating what the pathologies that lead people, even for those who may be having what is expected as a good antiretroviral, who continue to develop cognitive impairment and are virally suppressed. Now, there's one big controversy internationally when it gets to the testing, and that's the instruments. Because much of the time, the instruments are developed possibly in a higher income country, and then the work we do is mostly, as you saw with the second slide, the majority of the people are living in low and middle income countries. And that creates a challenge sometimes. And also, there is no harmonization on the kind of batteries that are used. Each research study may come up with their own battery for diagnosing, cognitive speed or working attention or, focused attention or working memory. And it becomes difficult for us to talk across different research groups. So we wish there was something that could be able to get us to speak the same language. So that remains as a problem internationally when you're doing assessments. People are going to talk about HIV and aging, and the previous speaker did speak about this, and the reasons as to why people may, have cognitive impairment, worse if they have HIV. And we do have running cohorts in Uganda, in Rakai, and in Bara, trying to understand what it is that happens to these individuals. We're yet to present results of this. And I'll not go into this since the previous speaker talked about that. And but the fact is that individuals who have HIV tend to have worse cognitive impairment, as the previous speaker also spoke about. So what insights have we learned through all these years are looking at HIV cognition? That the new severe cases are now very rare. So the prevalence is anywhere from 2 to 5%, depending on which study, and that's looking at HIV dementia. The cognitive impairment, MCI, is quite common, and as we've said, that it may be more for HIV-positive individuals versus HIV negatives, even if you compare it for ages. Now, the problem is that much of the researchers have concentrated on using just the instrumental, classification rather than putting into consideration the clinical evaluation and impairments that individuals may have, and that brings a challenge because then you tend to overdiagnose a couple of people. And even when you have the right instruments, sometimes there is an overclassification of about 20% of people who shouldn't be classified as cognitively impaired. The other thing to stress is the issue of the context. It is very important that we put into consideration things like education, culture. So the third presenter in the morning who was talking about gait and cognitive impairment, we always have that challenge in Uganda, because in Uganda we walk slowly. You say Ugandan somewhere. Yeah? Walking fast is not part of us, so but we get there. And then, of course, exposures through socioeconomic background and stuff like that. So it's important to put all these things together as one is looking at cognitive impairment. So there's been suggestions of a new approach to diagnosis. The HIV-associated brain injury. I was part of this work, and we're trying to suggest that, and I see another colleague in the room, that, looking at HIV, a cognitive impairment, that HIV itself is just one of the things that may be causing, the impairment on the individual. And we need to figure out how do we pull that out, minus all the noise of the, previous damage to the brain before antiretrovirals, the neurotoxicity that is, coming because of the drug, and the comorbidities individuals are suffering from. That we need to collect evidence of brain injury before we actually call it HIV-related dementia or associated dementia, and that there should be symptoms that are either observed in the individual by themselves or by others who are present with them, and not purely just go by, what we find on cognitive testing. And as we move forward, it's important for us to look into biomarkers that may be helpful in the diagnosing and giving the prognosis for people who may be identified as having cognitive impairment, especially if you're going to look at them in the long run. So we do have a summary of recommendations as to how you can look at these things. I've kind of just summarized that in the previous slide. And moving forward, what do we do for diagnosis and research? That we need to have a common methodology to quantify and describe cognitive impairment. Right now, a lot has been done, but more needs to be done. And when it gets to the delivery of antiretroviral therapy into the brain, because much of the time there's insufficiency in that, research can look into things like nanoparticles for effective passage and delivery of art into the brain. And we need to leverage computational methods such as machine learning methods in trying to put everything that we gather out of an individual before we can decide as to whether they have impairment or not. I guess which would also lead us to understanding the pathology that these individuals may be suffering from before we diagnose them as having HIV cognitive impairment. And for those that do have cognitive impairment, there's room for rehabilitation, because we talk a lot about, yes, they're impaired, then what do we do if the drugs themselves are not able to help them improve in their levels of cognitive functioning? So with that, I would like to come to the end of my presentation. I thank you very much for your attention.
Yeah.